All right, you know what time it is, so let's hop right on in. Uh, a lot of these are actually going to be straightforward, so today's going to be a bit of a shorter session, even with 6 studies. So just bear with me. First one, association between average daily activity and knee osteoarthritis. So what they found with this one, and what we've covered in other studies, let me shift my camera here, is that this is another U-shaped curve. Basically, on either extreme end of very, very sedentary and extremely active, you seem to have an increased risk of developing knee osteoarthritis, or at least the signs of knee osteoarthritis. And that is at least somewhat self-explanatory, because on the sedentary side, if you're not using it, it's not getting robust, you're not getting hydration to the tissues, you're not building additional structures and adaptations in the knee joint itself to allow for a healthy aging process. And then on the other side, you may be moving so much that your body wants to adapt to it, but doesn't have the materials such as nutrition, substrates, and time to recover from that. And it will adapt in this arthritic change to basically patch up in the short term what it has to do, because your brain and your body are always triaging. They're always adapting. Like what does your body need to do with the resources at hand for the task? I'm going to take a drink. Give me a sec. And so with the extreme end, where you're moving a whole bunch with minimal time for recovery, that could also basically make your body start adapting in these typical osteoarthritic changes to patch up what it has to do in the now, without having to think, oh, what is my knee going to look like in 20 years? It doesn't care. It's like, what does it need to do right now to accommodate for this level of activity? Now, it must be said that in this study, the average age was a little bit higher, with the age being about 63, 64 years of age, but still worthwhile to consider these adaptation changes. Now, in that middle of the U curve is kind of that sweet spot, the Goldilocks, where it's not too little, not too much. You have just enough activity to stay fit, stay healthy, let the body respond, and then recover from that level of activity. So the conclusion basically is the moderate level of activity may be protective against knee osteoarthritis progression, while the low and high levels may increase risk. And that's my understanding, at least as of right now in 2025, and my hunch as to why. So moving on to the next one. A description of serious adverse events following spinal manipulative therapy for adults with a history of spine surgery. A single institution, so one hospital, outfit, or clinic. Retrospective chart review. So they just basically took a look at these people at this hospital in their charts. Did they have surgery? If yes, then did they have post-operative spinal manipulative therapy? When did they have it? And were any bad things reported happening? Now, we've covered almost this exact same study before. So I'm going to kind of breeze right through it. Let's see here. They did this study between January 10th and December 2021 at an academic medical center in the United States. They found a total of 418 unique patient charts that were eligible for this type of review. The age was about 50 years. The skew was females, 52.6%, and white in the chart review. The most common types of surgeries were basically fusions, the low back, almost 29%, neck, 28%. And then the next most common type of surgery was a laminectomy or foraminectomy. So basically they remove parts of the actual vertebral body, typically to decompress it if they feel like it's compressing on a nerve, the spinal cord, or its nerve rootlets as it comes out of the spine. Now, here's one thing that I think sets these results apart, because oftentimes people think, oh, I've had surgery, therefore you cannot do X, Y, and Z to my spine. Your spine is very, very robust. You need enough time to heal from the surgery. And, outside of, look, there's always going to be exceptions to the rule. And I'm sure if I say just a blanket statement, like you can do anything with your spine after surgery, somebody's going to come at me and say, that's not technically true. But as a general rule of thumb, your body is very robust and able to adapt. And most of the things that you're able to do in a typical day-to-day life should be able to be done and accommodated with these surgeries. And in fact, that's kind of the point of these surgeries, is to get you back to doing things in your daily life. So something as mm, minimally invasive and low force as a proper spinal manipulative therapy intervention shouldn't actually be a huge consideration for harm when it comes to these post-operative patients. That's just the nature of the game. If you're able to go back to sport, back to your job, if you basically are, if you're able to sneeze really, really hard, which sounds goofy, but if you can sneeze really hard without pain or symptoms, I can't really, as long as I'm doing my job correctly, impart any additional force than what you can do on a day-to-day basis in pretty much any part of your body. Again, as long as I do it right. Now, there's always, again, exceptions to the rule, but that's generally how we are trained and understand this surgical process and adjustment process, because there's more studies coming out that are talking about how much force is being applied. Coming from a teaching college, so a chiropractic teaching college, that is part of their curriculum. I've seen it done. It was starting to be integrated when I was a student, and it is actually part of their core curriculum at the school, where they actually have force sensing plates so that students are always hitting certain force metrics. So we're really dialing in how much force is being applied to these joints, and it is nowhere near what some people or what a lot of people do in their typical day-to-day life. I'm getting off topic. Back to the study. The key thing here was the median time after surgery for the first adjustment was almost a year. So the better part of a year. That is big, because of course, if you do it in the post-operative, acute, subacute healing phase from that, you're probably going to have issues. The body is trying to deal with whatever happened during the surgery in the first place. So the time in between this intervention and the surgery, I think, is the biggest thing to take away from it, and to understand, like, hey, most of these people waited an appropriate amount of time, and it is therefore no surprise that the adverse events, which, forgive me, I forgot to say what they were actually measuring for. They were measuring for vertebral artery dissection. So what everybody is typically scared about when they hear cracking a neck, oh, you're going to sever my arteries. Cauda equina syndrome, fracture in the location of adjustment, or hardware failure in the region of spinal manipulative therapy within 10 days following that intervention. They found no incidence of those events in the short term in individuals with prior spine surgery in this study. So we're just layering it on as long as things are done right and an appropriate amount of time is being observed, you're not ruling yourself out as a candidate for this intervention should it be warranted for you. Next, clinical efficacy of athletic taping assisted physiotherapy for plantar fasciitis, a systematic evaluation and meta-analysis. Basically, I'll kind of go to the very, very end, so even past the conclusion. Due to the sample size of the studies and the heterogeneity, the above conclusions need to be evaluated further. So take this study with a grain of salt is kind of what that really means. So what did they actually come to the conclusion of? Based on the current evidence, early analysis, preliminary analysis suggests that KT tape combined with conventional rehab may have some advantages in improving pain and ankle hindfoot function and plantar fasciitis, or I can't speak today. Plantar fascia thickness in patients with plantar fasciopathy is what I'll call it. This is neat, and that's just with KT tape. Here at the office, we utilize dynamic tape, which is essentially, in my opinion, for conditions such as this, a step up, because you're actually going to get some elastic recoil and assistance and offload with it. So the fact that KT tape is showing some promising early signs for plantar fasciopathy just really lends itself to we're on the right track here at the office, and I can, in good conscience, use this intervention more. And it's showing that, hey, yeah, I'm not just guessing. I'm not doing an uneducated guess when it comes to using dynamic tape with my plantar fasciopathy patients. And I see that when we take care of it, we tape it on, and they're like, wow, majority of the time, as long as they do it right and we have the right condition, my foot pain is really, really low by comparison. I don't have to worry as much about those first 10, 20 steps in the morning. You still have to do it during certain stages. Like, yeah, the pain was still there, but instead of an 8, it was like a 4 with this stuff on. And that usually buys us a window to do some more fun stuff and get the person kind of redialing in the pain perception when it comes to plantar fasciopathy. But again, I can get off on a bunch of tangents with that. I want to get through these 3 studies because I'm quirky. Get used to it. This is my video. Deal with it. Evaluating the association between obesity and development of trigger finger and carpal tunnel syndrome. So basically with this one is over a 4-year period at a center, they found out that you had an increased risk of developing this diagnosis earlier than if you were a normal BMI. So the BMI cutoff is essentially if you were above 30. So patients with a high BMI above 30 were diagnosed with carpal tunnel syndrome or trigger finger at a younger age, which was about 6.5 years earlier than those of the normal BMI. And they wanted to show kind of a comparison. So comparing that to other conditions and more modifiable factors that predispose you to carpal tunnel syndrome, smokers develop it 12.5 years sooner. Type 1 diabetics develop it almost 20 years sooner. Hypertensive patients, so high blood pressure, develop it 6 years sooner. So we're kind of on par with this study to say that uncontrolled obesity is on par as a risk factor for developing carpal tunnel syndrome, the same incident rate earlier as patients with hypertension. So it is its own risk factor comparable with hypertension for this condition. And it's not, because that's carpal tunnel, it's going to be the wrists. So what gives? Typically patients are just like, well, I'm overweight, obese. I typically think it's going to be a load on my spine, hips, and knees. What's the deal with the wrists? Like I've talked about in prior videos, it is not usually or predominantly the mechanical excess load that the weight puts on your body that is the issue. It is the chemical, or think of it as your body's internal environment, that process, the chemical process, the inflammation, everything else going on with the excess body weight. That is the issue, which is why you probably develop this sooner. It could be an issue with the actual tissue distribution around the actual neurovascular sheath. It could be other central pain mechanisms where it almost starts off where you have like a central pain mechanism, but then you do something to kind of irritate your hands because, again, on a corollary, a lot of the times your excess weight is due to lifestyle factors, and predominantly the lifestyle factors that predispose you to being overweight is being sedentary, and that comes with a lot of office jobs. So you working with your hands and wrists in these locked in positions a lot without breaks may be one of those things where you're more prone to developing pain. You get a little irritation here, and now the added chemical effects of the excess weight don't allow you to recover from the pain soon enough, and you may develop essentially a secondary carpal tunnel syndrome. But again, that's digressing. That is clinical opinion and just complete speculation, but just keeping it in your brain as to why on earth would this happen? There's a lot of potential reasons. But rather than just speculating, this study is saying, hey, we need to do something about your weight because it could have far-reaching effects. So keep that in the back of your brain as we finish up these last 2 studies. Causal association between coffee and migraine using a randomization analysis. So this one is just a little fun one. Hey, tickles my bias because I love coffee. And this is one where, but wait, I thought migraines and coffee, I thought caffeine was a trigger. Yes, for some. So when we have this discussion when it comes to migraines are very, very complicated. There are clinics that dedicate their entire patient base, their entire approach just to the intervention and condition of migraine headaches. They are multivariate. They are complicated. They are not terribly well understood because they are so variable between individuals and their entire process. They're not like, this is a bit morbid, but they're not like a brain bleed headache where it's just like, you develop like, you get knocked on your head, and all of a sudden, a couple days later, you just get this bleed. It's like, oh, such a bad headache. You have very, very clear symptoms, very, very clear process, and a very, very clear resolution. You get it in your brain, basically gets additional room, bada bing, bada boom, you're good. This is essentially an extremely complicated uh, condition that has a lot of factors such as genetics. So if you have a history of fibromyalgia, you're more prone to getting this. There's neurochemical conditions. So if you have, let's see if I remember right, if you're predisposed to developing anxiety, depression, you're more likely to get these things. If you have central mechanisms in your brain that don't mitigate pain very well, you're more prone to getting these. So it also makes sense that for a lot of people, maybe caffeine is the trigger because of what it does to your vasculature. Caffeine as a drug itself or a substrate itself is understood. But in others, it could be protective because caffeine, I mean, take a look at, what was that over-the-counter medication that I remember? Excedrin had caffeine in it because caffeine, what it does to the vasculature, can help with a lot of different headaches, whether it is hypertensive headaches, like acute hypertensive headaches, not chronic hypertensive headaches, cervicogenic headaches, tension headaches. And so they wanted to see, hey, could this also be potentially protective in migraines? And basically, yes, they try and understand it like, oh, maybe it's the methylxanthine that lowers the risk. Maybe it's the caffeic acid sulfate, yada, yada, yada. That makes it higher risk. Basically, it's very individual. So this one tickles my fancy because I love coffee. And for those people that suffer with migraines, a lot of them will just hear caffeine is a trigger, period, and then they'll cut it out entirely. And black coffee can be part of a very healthy diet. So if it's one of those things that you're willing to trial and just journal, maybe it won't just be maybe it won't be a trigger, maybe it may even be a protector. But again, it is at this point, at this stage, very individual. I do not want to take coffee off your plate, but don't go doom and gloom like I'm a migraine sufferer, I must cut coffee out of my diet. Not necessarily. We may be able to do a trial and it may actually work the other way for you. It's just this condition is so complicated that you're going to see both sides of these studies where it's protective, it's not, it's protective, it's not. There's nuance. It's variable. That's what I'll end that study on. So the last one that I want to cover today, the efficacy of self-exercise in patients with cervicogenic dizziness, a randomized controlled trial. So there's a lot of different things that can cause dizziness, and it's one of the things that we really try and make sure that we screen correctly for in the office because it frankly can be scary on both sides of the equation. You know, as a patient myself who's had this, it can be scary because your brain goes through things like, all right, given my age and what I've done, what possible reason could I be this dizzy? All right, there's the common ones, the most likely ones, and that gives you a little bit of comfort. So it could be benign positional paroxysmal vertigo. So the little balancing apparatus in your inner ears could be off. That's common enough. It could be cervicogenic, which is what this study is talking about. So the interplay between your entire vestibular system in the brain with your eyes, your inner ear apparatus, and your neck, something is wonky in the neck. That's feeding some bad information to the brain, and it's dealing with three variables in this balance equation, and one of them is off. It's kind of like, whoa, what's going on? So that's this one. But again, it's scary because then you always think about, even though those are the common ones, what if it's a tumor? What if it's a blood issue? What if it's? So I understand, and it's one of the things that we screen for. There are certain thresholds and cutoffs that make it more likely to be a benign cause of dizziness and vertigo, i.e. benign paroxysmal positional vertigo and cervicogenic vertigo. There are cutoffs that might mean it's more likely to be like an inner ear infection. And then there's certain things that you can test for that make it more likely to be like a brain-based thing. But I digress. Let's get back to this one. This one, it's I don't want to say it's personal, but it's recent, it's fresh, because just a couple weeks ago we have had a patient like this, and we're finding that this person is very touchy when it comes to their brand of vertigo, but they did find almost these exact same results in the study when we implemented almost very similar self-exercise selection for them at home. So what am I getting at here? Patients with non-traumatic, that's big, neck-based dizziness were assigned to either a self-exercise group or a group that did nothing. They evaluated them using a neck pain, dizziness symptom, and a dizziness handicap inventory questionnaire, a neck disability index scale, and the visual analog scale. Why did I list those out? Because it's important when it comes to the conclusion. The objective outcomes, so what a clinician could measure, included range of motion of the neck and posturography test. Basically, could the patient recreate a similar posture? And in some of these posturography tests, they will actually do variable kinetic testing. So they actually have the patient close their eyes, move their neck around, and tell them, hey, get back into this position that you started at the beginning of the test. So it may be, perfectly neutral, close your eyes. The practitioner will move the head and hold it in a certain position. It's like, now bring it back to where I had it at the beginning. Boom. And then how far off are they from, the start position? And that kind of gives you an idea of where their control and communication is at when it comes to their neck. So what they found was that 32 patients participated in the study. The average age was 48. And what they found was the scores, so the self-assessment scores for the dizziness handicap inventory in the self-exercise group was significantly lower compared to the control. The neck disability index score after treatment was also significantly lower in the exercise group. And here's the interesting thing. There was no difference in pain, range of motion, or the posturography test between the two groups. No other side effects were noted. So basically, giving these patients these exercises didn't improve measurable from the doctor's side, measurable outcomes. Their neck range of motion didn't improve. Their pain didn't improve whatsoever with the exercise. However, giving them things like stability exercises, ocular exercises, various at-home exercises, and I think they listed out here. Let me find it here. Here it is. Muscle mobilization and ocular motor training at home improved self-reported improvement in their dizziness symptoms, which is huge. And that's something that, again, I note with a lot of these patients is even if there's no initial obvious objective measurement that they're improving, they feel better. Their communication between the neck and the brain seems to be improving, and that reduces the skew essentially of the equation of how far off is what they're seeing, what they're, where they're at in space and what their neck is telling them. The brain has less to juggle and the symptoms seem to kind of come down and relax a bit. So this is really a cool study in the sense that it backs up what we're doing here in the office. And we don't always have to have, because I love taking my devices here and actually measuring, like, yeah, you are actually improving, but sometimes we can't rely purely on an objective measure. Sometimes it does come down to subjective, as much as it doesn't always leave a good taste in providers' mouths, because we're all about, you are improving, we are doing a good job. But it's why we also spend time and talk with you. Are you actually improving? That's why we use most of these same indexes. We actually use the neck disability index. Are you improving over the course of care, whether we can measure it or not? And in something that is basically entirely symptom-based, not necessarily always sign-based, so things that patients report that they can only feel, not things that I can always see. It is really, really cool that we can at least give them things to do at home that will improve these symptoms in conditions that are or can be scary, debilitating, and giving you a hand back at the wheel can be so empowering. So that's what I'll leave it at this week. Thanks for sticking with me. Until next time.